Nonsteroidal anti-inflammatory drugs, or NSAIDs, are among the most commonly used medicines worldwide. They are effective for a wide variety of conditions due to their broad analgesic, anti-inflammatory, and antipyrec effects. NSAIDs are often preferred over opioids for pain management, especially in conditions like osteoarthritis, headache disorders, acute musculoskeletal injuries, dysmenorrhea, and dental pain. However, choosing the right NSAID involves balancing benefits and risks, considering each patient's unique health profile. This video will guide you through the essentials of NSAIDs for pain, their efficacy, safety, and how to select the most appropriate option. NSAIDs play a crucial role in reducing the burden of acute and chronic opioid use. While opioids are often prescribed for pain, NSAIDs are usually more appropriate for many conditions such as osteoarthritis, where they provide greater pain relief than paracetamol or opioids. The shift towards NSAIDs helps minimize opioid-related risks, including dependency and adverse effects. Understanding when to use NSAIDs instead of opioids is key to safer pain management, and this decision should always be guided by the patient's condition and risk factors. NSAIDs are classified based on their selectivity for cyclooxygenase COX enzymes, COX-1 and COX-2. COX-1 is a constitutive enzyme important for normal physiological functions like protecting the gastrointestinal tract and maintaining renal function. COX-2, on the other hand, is induced during inflammation, leading to pain, fever, and swelling. Non-selective NSAIDs inhibit both COX-1 and COX-2, while COX-2 selective NSAIDs target only COX-2, aiming to reduce gastric side effects. However, in practice, both types have similar safety considerations and their selection depends on individual patient risks. NSAIDs inhibit the activity of COX enzymes, which metabolize arachidonic acid into prostaglandin H2. Prostaglandins are signaling molecules that modulate pain, inflammation, fever, and vasodilation. Thromboxanes, also produced in this pathway, are involved in platelet function and hemostasis. By blocking COX enzymes, NSAIDs reduce the production of these molecules, thereby alleviating pain and inflammation. This mechanism underpins their effectiveness in a range of conditions, but also explains their potential side effects. Osteoarthritis is a common indication for NSAIDs, often more effective than opioids or paracetamol. NSAIDs significantly reduce pain in knee and hip osteoarthritis, improving function and patient assessment. They also help with grip strength and hand osteoarthritis. By targeting inflammation, NSAIDs address the root cause of pain in these conditions, making them a preferred choice. However, their use must be balanced with potential risks, especially in older patients or those with comorbidity. Axial spondyloarthritis, including ankylosing spondylitis, is a chronic inflammatory disease characterized by lower back pain. NSAIDs combined with physical therapy are considered first-line management. They slow disease progression and improve symptoms. While all NSAIDs are effective, some evidence suggests edoricxib may be superior for this condition. Choosing the right NSAID involves considering efficacy, patient preference, and safety profile. NSAIDs are widely used for acute pain management, including headache disorders, musculoskeletal injuries, dysmenorrhea, and dental pain. Their effectiveness is well established in these conditions, providing rapid relief and improving function. For acute pain, NSAIDs with short half-lives such as ibuprofen or diclofenac are easier to titrate and may be preferred. Combining NSAIDs with paracetamol can enhance pain relief, often outperforming opioids. NSAIDs provide effective symptom relief in rheumatoid arthritis and acute gout. They are often used before the full effect of disease-modifying drugs is achieved. While alternatives like glucocorticoids and colchicine exist, NSAIDs remain a valuable option for managing pain and inflammation in these chronic conditions. Their use should be tailored to individual patient needs and risk profiles. NSAIDs are not considered effective for nociplastic or neuropathic pain. These types of pain are not primarily mediated by prostaglandins, which are the main targets of NSAIDs. For neuropathic pain, other medications and therapies are required. Understanding the limitations of NSAIDs helps ensure appropriate pain management and avoids ineffective treatments. NSAIDs can cause mucosal damage throughout the gastrointestinal tract, leading to dyspepsia, ulceration, bleeding, or perforation. COX-2 selective NSAIDs were developed to reduce these complications, but adverse effects can still occur. Celecoxib has the lowest gastrointestinal risk, followed by ibuprofen. Proton pump inhibitors can reduce upper GI complications but do not protect the lower GI tract. Patients with existing GI pathology require careful monitoring when starting NSAIDs. All NSAIDs, especially COX-2 inhibitors, are associated with increased cardiovascular risk, including hypertension, heart failure, and myocardial infarction. Naproxen and low-dose celecoxib may have lower cardiovascular risk compared to other NSAIDs. Higher daily doses increase overall risk. NSAIDs should be avoided in patients with moderate to severe heart failure. The decision to use NSAIDs must weigh cardiovascular risks against potential benefit. NSAIDs can cause adverse renal effects, especially in patients with pre-existing renal impairment. Risk factors for acute kidney injury include volume depletion, older age, and concurrent use of nephrotoxins. NSAIDs should be avoided in patients with a glomerular filtration rate, GFR, less than 30 ml/min. For those with GFR between 30 and 60 ml/min, long-term NSAID use should be considered only if no other risk factors are present. The triple whammy combination of NSAIDs, diuretics, and ACE inhibitors or ARBs increases renal risk. NSAIDs should be avoided in patients with hepatic cirrhosis. Most NSAIDs are metabolized in the liver, and the production of reactive intermediaries can cause liver damage. Diclofenac has the best defined risk of liver injury, with a 3% risk of meaningful transaminase elevation. NSAIDs may also precipitate other problems in cirrhosis, including hepatorenal syndrome, GI bleeding, worsened platelet function, sodium retention, and edema. NSAIDs may contribute to clinically significant bleeding due to gastrointestinal ulceration. Combining NSAIDs with anticoagulants doubles the risk of significant bleeding. Not all NSAIDs have the same antiplatelet effects as aspirin. NSAIDs have also been associated with increased thrombosis risk, including a doubling of risk for venous thromboembolism. These risks must be considered, especially in patients with bleeding disorders or those on anticoagulants. NSAIDs can cause non-allergic hypersensitivity reactions, often due to COX-1 inhibition and overproduction of leukotrienes. This can lead to urticaria or angioedema. NSAIDs can also worsen asthma in some patients. Allergic hypersensitivity reactions, including anaphylaxis and Stevens-Johnson syndrome, are possible. Selective COX-2 inhibitors are less likely to cause cross-reactive hypersensitivity. Understanding these risks is crucial for safe prescribing. NSAIDs should be avoided in the first trimester of pregnancy due to increased risk of miscarriage. They may be considered in specific situations where benefits outweigh harms. Exposure in the third trimester is contraindicated, especially after 30 weeks, due to risks like oligohydramnios and early closure of the fetal ductus arteriosus. Short-acting NSAIDs are considered safe during breastfeeding, except for high-dose aspirin. Head-to-head trials compare NSAID efficacy, but most are similarly effective for pain. The choice of NSAID is often dictated by adverse effect profile and patient preference. For acute pain, short half-life NSAIDs like ibuprofen or diclofenac are easier to titrate. For chronic conditions, longer-acting NSAIDs like celecoxib, meloxicam, or naproxen are more convenient. COX-2 selective NSAIDs are recommended for those with higher gastrointestinal risk. Proton pump inhibitor (PPI) therapy should not be routinely co-prescribed with NSAIDs, but is recommended for patients with upper gastrointestinal risk factors, such as older age, history of peptic ulcer disease, or concurrent glucocorticoid therapy. PPIs lower the risk of NSAID-associated upper GI complications, but do not protect the lower GI tract. Patients with existing lower GI pathology require clinical monitoring when starting NSAID. Need to take NSAIDs with food remains controversial. Animal studies suggest fasting increases gastric adverse effects, while food increases small bowel damage. NSAIDs reach maximum plasma concentrations faster when taken with water. For acute pain, faster onset may improve pain control and reduce total NSAID dose. For long-term use, this is less significant as steady state is reached. Certain conditions require specific NSAIDs. For example, paroxysmal hemicrania and hemicrania continua, two primary headache syndromes, only respond to indomethacin. For short-term intravenous or intramuscular administration, ketorolac is the primary NSAID used. High-dose aspirin was historically used for musculoskeletal pain, but is now superseded by newer NSAIDs due to toxicity. Topical NSAIDs are better tolerated than systemic NSAIDs, with minimal systemic absorption unless used in high amounts. Their main adverse effect is local skin irritation. Topical NSAIDs modestly reduce pain and functional impairment from sprains, strains, and hand and knee osteoarthritis. They are usually considered adjunct therapy, providing limited local benefit. Most NSAIDs are metabolized by cytochrome P450, CYP2C9, especially celecoxib, ibuprofen, meloxicam, and piroxicam. Impaired CYP2C9 function, either from genetic polymorphisms or co-administration with inhibitors, can lead to higher NSAID concentrations and increased toxicity. Understanding metabolic pathways helps guide safe dosing and selection, especially in patients with known metabolic issues. Risk of impaired bone healing from NSAIDs remains controversial. While it is plausible that NSAIDs could affect bone healing, shorter-term use and lower doses appear to confer minimal risk. This is an important consideration for patients recovering from fractures or orthopedic surgery, and decisions should be individualized based on risk and benefit. NSAIDs vary in their route of administration and dosing frequency. Some are available orally, topically, rectally, or intravenously. Dose frequency ranges from every 4-6 hours for short-acting NSAIDs like ibuprofen, to once daily for longer-acting options like meloxicam or etorixib. Choosing the right NSAID and dosing schedule depends on the condition being treated, patient preference, and risk profile. NSAIDs differ in their gastrointestinal and cardiovascular risk profiles. Piroxicam, etorixib, and ketorolac have high GI risk, while celecoxib and ibuprofen have very low GI risk. Cardiovascular risk is highest with etorixib and ketorolac, and lowest with naproxen and celecoxib. Understanding these differences helps guide safer NSAID selection for individual patients. NSAIDs are underutilized in some situations and play a role in reducing the burden of acute and chronic opioid use. By providing effective pain relief, NSAIDs help avoid opioid-related harm, including dependency and adverse effects. This opioid-sparing strategy is increasingly important in modern pain management, especially for musculoskeletal conditions. NSAIDs are widely recognized as effective for most dental pain. Their anti-inflammatory properties help reduce pain and swelling, providing rapid relief. NSAIDs are often preferred over opioids for dental pain due to their safety profile and effectiveness. Combining NSAIDs with paracetamol can further enhance pain relief. NSAIDs are effective in treating headache disorders, including migraines and tension headaches. They provide rapid relief by targeting inflammation and prostaglandin-mediated pain. For certain headache syndromes such as paroxysmal hemicrania, indomethacin is uniquely effective. NSAIDs should be chosen based on headache type, patient history, and risk factors. For chronic inflammatory conditions, longer-acting NSAIDs like celecoxib, meloxicam, or naproxen are more convenient. These options provide sustained pain relief and are easier for patients to manage. COX-2 selective NSAIDs are generally recommended for individuals with higher gastrointestinal risk, especially those older than 65 years or with peptic ulcer disease. NSAIDs have an important place in pain management, often more appropriate than opioids. While most NSAIDs are comparable in efficacy, their adverse effect profiles and pharmacokinetic properties guide selection. Topical NSAIDs are better tolerated but provide limited local benefit. Safe prescribing requires consideration of gastrointestinal, cardiovascular, renal, hepatic, and hypersensitivity risks, as well as patient-specific factors. Always tailor NSAID choice to the individual, balancing benefits and risks for optimal pain management.